Hi, welcome everybody. My name is Dr. Rachel Giles, and I am the chair of the International Kidney Cancer Coalition, and it's my honor today to be moderating the Talking Treatments global webinar, and we are looking mostly at the variations in the global access to treatments and what options are. So I'm welcoming everyone here to World Kidney Cancer Day. We do this is our 6th iteration, and it is a moment to pause and think about how we can relieve the world of kidney cancer and make it a more bearable disease. So around the world, we know that many kidney cancer patients aren't aware of the treatment options available to them, including options and access to clinical trials. And they don't feel either informed or empowered enough to ask. And on the other side of the desk, from the professional point of view, for various reasons, initiating the conversations with the patients about treatment options isn't going as well as we'd hope. The objective of the World Kidney Cancer Day this year in 2022 is to promote more and better quality conversations between kidney cancer patients and their professional team. So I'm here today we have basically 2 sets of panels, and we have plenty of room for discussion and questions. There's a chat box on the side. You're welcome to submit questions. We have some questions already submitted as well. And I'd like to start by also pointing out that it's important to recognize that there are lots of different geographies available and different access to different types of care in those geographies. And we are very respectful of everyone's access and what they have a right to. So this webinar is an excellent spot to bring up the obstacles that are being met and the ways and solutions perhaps that people are finding to work with that. But what it's not about, just to be clear, is not about specific drugs or specific treatments. And we would prefer if people did not mention drug names or specifics in that respect. So anyway, thank you very much. I think this will be a very, very interesting discussion, and I look forward to it. So I'd like to start off by showing a 2-minute World Kidney Cancer video, 2022. And I should also point out that this webinar is being recorded, and links to the subtitled versions will be available in about 24 hours, and those subtitles will be translated into various languages. So I hope that you're able to watch this video tomorrow in your language of choice. So thank you very much. Could we play the video, please?
In modern cancer care, patients and their doctors making treatment decisions together is recognized as best practice. But when it comes to kidney cancer, studies show most patients don't ask about treatment options. And most doctors don't talk about them either. Sometimes it's because patients don't feel they know enough, or they don't think they can question their doctor. Other times it's because doctors don't want to overwhelm their patients, or their appointments are too short. So this World Kidney Cancer Day, we want to create more and better conversations between patients and their clinical teams about all aspects of kidney cancer treatments, including access to clinical trials, both in your own country and overseas. Studies show most kidney cancer patients would seriously consider being part of a clinical trial if they were asked, but around half of them are never asked. To help patients and their doctors have better conversations about treatment options, we've created a list of questions which you can download from our website. They're the 6 questions every kidney cancer patient should feel able to ask their doctor. And we're encouraging all kidney cancer specialists to talk with all their patients about all their options. On World Kidney Cancer Day itself, we're holding a landmark global webinar to help make sure that wherever possible, every treatment decision is a shared decision. We need to talk about treatment options. Find out more, download the 6 questions, and register for our Talking Treatments webinar on World Kidney Cancer Day, June 16th.
Wonderful. I'm so glad that the team that pulled together the World Kidney Cancer Day, they did a fantastic job making that video, and hopefully that those 6 questions you've already downloaded and taken a look at them and how to possibly promote a better quality conversation between the patient and the clinician. So today we're going to kick off with a health professionals panel, and we have 2 fantastic health professionals present. So first I'd like to introduce Professor Eric Jonasch, and he's from MD Anderson in Texas. Welcome, Professor Jonasch.
Great to be here, Rachel.
Thank you so much for joining us. And next, we're also quite honored to have another health professional joining with us from South Africa, Durban, Dr. Poovan Govender. Welcome.
Hi, listeners. Nice to be here.
It's lovely to have you both. So I'd like to start off perhaps asking Dr. Jonasch, what represents a quality conversation between treatment options, in your opinion?
Yeah, great question. And I think the 2 elements here would be objective and empathetic. So, the purpose of this conversation between the doctor and the patient, and I would say the doctor and the patient's family, is to make sure that the patient obtains the necessary information about available treatment options. And this needs to be a conversation where, you build trust between the physician team and the patient and caregiver team. There has to be, the things that I see as being really helpful would be having additional family members in that conversation to make sure there are more ears and more minds capturing the information, which can sometimes be overwhelming. Making sure that, I would say homework for the patient and caregiver and family is bring in a list of questions of things that you do want to ask the doctor and the doctor's team, and make sure that those questions are answered. So in the end, having this conversation, even recording it in a way that the patient and the patient's family feel that they are informed about available options is key.
All right, and Dr. Govender, do you have anything to add to that?
Yeah, I think there's essentially 2 components. One is the content, and 2 is the way we impart that content. When we go through the content, I think the important objectives are to help patients understand the goals of treatment, helping them distinguish between what we call curative treatments and palliative treatments, helping them understand the different treatment options available, and how we come to what we call evidence-based medicine. Also bearing in mind that in some parts of the world, like South Africa, there are enormous resource constraints in terms of accessing some of these wonderful new drugs on the market. And while we may have lots of excellent drugs, sometimes as a clinician, it becomes quite challenging to tell a patient that we have excellent drugs that can help give you durable survival, and yet can't offer to you. And that probably lends itself to a discussion about the access to clinical trials. Another important element would be the impact of these treatments on patients' quality of life. And that's where it's important to know your patient, understand what they're passionate about. Can they still walk their dog every day? Can they play golf on a weekend? And then once you've empowered your patient with sufficient knowledge, then you get to the element of shared decision-making, where the patient now has sufficient knowledge to decide together with the clinician how to chart the journey forward. Another important element that I alluded to earlier on was the way we impart the content. And a few fundamentals is to create a conducive environment where the patient feels like he's talking to a friend. the patient needs to feel like he's at ease. And the important principles therein is obviously to allow the patient unrestricted access to your time, undivided attention, trying to strip the conversation of medical jargon as far as possible. And I think one of the challenges we had during COVID was, the use of body language. Sometimes when you're telling a patient that they've got incurable cancer, just holding their hand while doing so, or putting your hand on their shoulder, is so important, or adjusting your tone of voice. So I think, this consultation about discussion of treatment options forms the bedrock for a successful relationship, a long-lasting relationship built on trust and honesty. And as clinicians, we've got to be, mindful of that, and also let the patient know when we're telling them something like they've got incurable cancer, that we also understand the gravity of the information we're communicating, and we've got their back. We're in their corner with them, fighting in the trenches with them.
That is extremely well stated. So, Dr. Yonesh, could you actually add to that? What are some of the other barriers that might be? I mean, Dr. Govender mentioned the communication, but also access to treatments and access to trials. What other barriers do you think there are that might be contributing to unsuccessful conversations?
Yeah, I think there's a number of things. I mean, first of all, obviously, language barriers. We have to make sure that we're able to truly communicate with our patients in a way that they truly understand. The time pressures that physicians and physician office sometimes face, there's nothing like having the sense of being rushed through a conversation to make it more difficult for the patient and family members to be receptive to that conversation. And also, I think, the emotional state, when one is diagnosed with a devastating illness, being able to actually hear what's being said is challenging. And I think that, this is where it comes back to the idea that, you have a team, that the patient has their team who help them in terms of their relatives and friends for that support, that the physician team really is attuned to the emotional state of the patient, and we make sure that things like repetition are there, so that things are not heard once but are heard more than once, to ensure that real communication is occurring.
And Dr. Govender, are there certain techniques that you can use to try and get the best, what you want to get out of a conversation with your patient? How do you go about that? How do you prepare for that conversation, and what do you consider a successful conversation?
I think that it kind of lends itself from the barriers to a successful consultation. I think the first and foremost thing is that we form, as oncologists, we form long-term relationships with our patients. And any relationship, needs to be built on honesty, trust, helping patients know that there's also deficiencies in our knowledge base as well. So I think we're all wired differently. Patients come from different cultural backgrounds, socioeconomic backgrounds, linguistic backgrounds. And for the clinician, it's important to be adaptable. And I think that's critical. There are some patients that want to know the mechanism of action of pembrolizumab, and there are others that just want to know that they're going to be able to attend their daughter's wedding in 3 months. Yeah. So I think that for clinicians, you've got to think on your feet, understand the depth of knowledge your patient wants, and adjust accordingly.
Right. And to both of you, actually, so how do caregivers fit into this whole picture?
Yeah, the caregivers are critical. This is I see this sort of, it's not the patient alone that's in this journey. It's the patient, the caregivers, family members, and providing that support that helps the patient get through this journey is critically important. And I think this ends up helping the patient. It also helps the caregivers who then have a real role in the care of the patient. Helps, I think, both sides, the physician and caregivers and the physician team as well as the caregiver team. So I think we have to really have this team effort where patients, their family members, their caregivers, their loved ones are really integrated into the care of the patient.
All right, Dr. Govender, can I give you the last word before we move on to the next question? What do you think is the best way to approach these conversations and include the caregivers?
I think it's essential that caregivers be allowed carte blanche to visit as often as they want to, keeping open lines of communication, because we all know that we can only do this as a team approach. And yes, the clinicians and the nurses are on hand when the patient comes through with side effects. But what about when patients have side effects from treatment at home? That's when the caregiver needs to know about what diet, how to modify the diet, what drugs to use. I think it's essential that the caregivers are critical components of the management team. And it starts from that first consultation when we're discussing treatment options, where I always encourage a second pair of ears to come in so that they also have insight into what's going on. So yeah, I think it makes a world of difference when you have a solid caregiver in the patient's corner.
All right, thank you so much. So could I introduce the next slide, please, technical team? Thank you so much. So when and how do you talk with patients about clinical trials? And I think this is a big, juicy question. So Dr. Yonash, could I ask you to kick it off, please?
Yeah, so I think it's an important conversation to have, maybe even at the first conversation and definitely at the second conversation, when the options that are available are being laid out. You say there's what we would call standard of care options, as well as then experimental options, and providing these options to the patients and the caregivers relatively early on, so they can help in this shared decision making of what the best treatments are, needs to occur. And sometimes there are no clinical trials that are appropriate. I think that can be stated as part of the treatment choices, saying at this point in time there are none. But if there are, I think having an unbiased sort of presentation of what's available, both within your own institution as perhaps in the broader sort of context of your healthcare environment, is important.
And Dr. Govender, what would your approach be there?
I've already highlighted that resource-constrained environments, we don't often have access to standard of care treatments. So for us, it's really important for us to be able to offer patients clinical trial access as an alternative to accessing some of these newer drugs. So for us, it's a very important part of the conversation. And naturally bearing in mind that there aren't always clinical trials available for renal cell cancer, but certainly if they are available, we always put it forward to our patients. So it's usually in the context where we don't have standard of care options to offer, either because there's no drug available or there's healthcare insurance restrictions. It's when we're running out of standard of care treatment options, or when we're dealing with unusual renal cancer entities like non-clear cell renal cell carcinoma as well.
Right, where you're just taking a sort of an educated guess based on limited evidence.
Quite right.
Yeah. Okay, and large organizations, like you're in a very large organization, Dr. Yonash, where many clinical trials are running at the same time. From a, just to give an idea from the patient point of view, they don't even know how this process works. Can you just give a slightly quick insight into how does that look like? How do you know which clinical trials are running in your institution even?
It's actually a struggle for the busy physician as well, to know exactly what clinical trials are available. And I think it's part of our duty to our patients to really know what is available. And we have an organizational structure at our institution where we actually have monthly meetings with the physicians who treat renal cell carcinoma, where we now have databases and websites that allow us to be able to look at these things in a fairly easy manner. And I have to say that a couple of years ago, even this wasn't as sophisticated. So I think it's sort of one of those things that we are continuing to struggle with in terms of making sure that we have these things at our fingertips when we're having that busy consultation, that we can think of these types of options for our patients. The more we can actually improve that access, both for the physicians as well as for the patients, I think it's going to improve care overall.
Right. And Dr. Govender, for countries that do have limited resources, how can patient organizations or patients and patient advocates actually try and leverage clinical trial access in countries?
Yeah, I think the challenge for us is we don't have too many clinical trial sites to start off with, because they often require lots of resources, human resources, and the practice where I function in, we don't actually do clinical trials. So like Dr. Jonash has already stipulated, it's always a struggle to find out which clinical trials are running. We also have a website which unveils which are the clinical trials running at any point in time. We often use that and update ourselves on which clinical trials are running, to then be in a position to know whether they are in fact clinical trials for renal cell cancer. But what can advocacy groups do? You know, a whole host, I suppose. And it all starts down with funding, I suppose, because the restrictions are largely, you've got a scarcity of oncologists in a country. The oncologist to patient ratio is certainly discordant, and I think it's important that we overstretched. We're not in a position to treat a single malignancy. Most oncologists in South Africa function as generalists, where we're treating all solid organ cancers. So yeah, I think we need funding resources, we need personnel resources. So there's a whole host that can be done in resource-constrained environment, try and help us to level the playing fields.
Right. And of course, there's a lot of interesting work going on now with registries as well for real-world evidence, which may not be, investigational trials, but it is very important information, and that's being largely driven by countries with limited resources. So thank you both. I think I'd like to actually take this moment to move on to our patient and caregiver panel. So thank you both for your very interesting contributions here. And I'm going to invite the next people. Could I have the next slide, please? Thank you. So here we're going to hear from a patient's point of view and a caregiver's point of view. And we have two patients and one caregiver that have volunteered their time. And I'm going to kick off with Megan Connolly from the United States, who's a patient, and she's going to tell her story for a few minutes. Next, I'm going to have Amy Fraser from Canada talking. She's also a patient. And lastly, but definitely not least, is a caregiver, Hitesh Shah, and he's in India. And I'd like to give you all an opportunity to tell a little bit about yourselves and what does a quality conversation about treatment options represent for you? Amy, could you please, sorry, Megan is first. Sorry, Megan.
Thank you. Hello, everyone. In 2020, I was incidentally diagnosed at 33 with chromophobe renal cell carcinoma while undergoing various tests for infertility ordered by my OBGYN. I had had multiple ectopic pregnancies and a history of fibroids. And so, during the course of getting scans, I was initially diagnosed with a 4.2 centimeter angiomyolipoma, which is a benign mass of the kidney. Since I was trying to get pregnant and I was concerned about the effects of pregnancy hormones and the growth of the mass and risk of rupturing, I decided to contact a urologist to explore further. And after several months and additional scans, I was diagnosed with cancer. I think it's important here to note that, it's important for patients to have self-awareness of their bodies. And if something doesn't seem right or you want more answers, then to push for further exploration. I was incidentally diagnosed with something thought to be benign, but I decided to seek more information and guidance, which ultimately led to my cancer diagnosis. As mentioned previously during this panel, educate yourself, don't be afraid to ask questions. And, there's always resources you can utilize offered by the IKCC and other kidney cancer organizations. I would also say that, getting a cancer diagnosis and meeting with doctors can be a very overwhelming and intimidating process. My initial doctor, whom I received the news from, he did not want to biopsy my tumor. He wanted to proceed with surgery, but was unable to tell me if he would be able to perform the surgery robotically, or if it would require a full incision, or whether or not it would be a partial or radical nephrectomy. I wanted the cancer out as soon as possible, but I also felt like at the time I was being rushed into something that didn't feel right to me. So I decided to get a second opinion, and my second doctor, and the one I ultimately went with to perform my surgery, had an entirely different approach. He wanted to biopsy the tumor for two reasons. One, I didn't fit the clinical profile of a kidney cancer patient, and he said there was a 10% chance that it could be a fat-poor angiomyolipoma, which is commonly misdiagnosed as cancer based on imaging alone. And he didn't want to remove all or part of my kidney if it was unnecessary to do so. And secondly, he said, if it is cancer, I want to know exactly which type it is, and that will help me determine the best surgical approach. And that made sense to me. So I think, it's really important that, participatory medicine, meaning you as the patient and the doctor collaborate on deciding the plan for you, is so important. And, work with a doctor that doesn't rush you, but listens to you and helps identify a plan that aligns with what you want as the patient. And if there's anything I've learned, it's really, you have to be your own advocate when it comes to your health, and you really have to be the driver in managing your treatment. And I think I would just conclude with, through when I was going through the process, what was incredibly helpful to me was having support of family and friends, especially when you're going to your appointments. They can help you digest very important information and complicated information, and help you ask questions. That's what I would recommend.
Thank you so much. Those are incredibly useful insights. Amy, could I ask you to please say what do you think is a quality conversation from your point of view, and tell us a little bit about yourself?
So my name is Amy Fraser. I am a patient, and I live about an hour west of Toronto in Ontario, Canada. I'm incredibly lucky to live where I do and have access to as many treatment options as I do. So please know that privilege is not lost on me. I was diagnosed with renal cell carcinoma in the fall of 2019. I was stage 4 with numerous nodules that had metastasized to both lungs right from diagnosis. I've had a radical nephrectomy, and I'm currently receiving treatment for the metastases. When it comes to conversations about treatment options, one of the best bits of advice that I was given was to not be shy about getting second opinion. Sometimes it's the same options that are presented to us differently. Sometimes we as patients are better able to hear and receive the information when we're talking things through a second time with a different doctor. Sometimes you do get a different opinion on which treatment to consider, and sometimes another option is presented altogether. So don't be afraid about asking about the second opinion. I've learned, particularly in the case of first-line treatments, when your cancer has not yet been introduced to any drugs, to ask if selecting one option would then close the door to another option in the future. And then I think the physicians have already touched on this, but if it's not presented to you, make sure you ask about clinical trials and how that all works. I've been completely spoiled with great doctors throughout my journey. In my case, doctor number 1 was concerned about my history of Crohn's disease. He presented all the options to me, but strongly advised against one option, as he was worried about how my body would tolerate it. He had very good reason to be concerned, and I appreciated his advice. On a side note, he was right. Doctor number 2, he presented the identical treatment options with the same statistics to help me with my decision making. I was a patient who wanted as much information as possible. So all of the statistics, the background information, that was good for me. The difference with doctor number 2 is that he included strategies that we could use to help mitigate things in case we ran into a problem, like having my Crohn's disease flare up or the cancer not respond as we had initially hoped. So don't be afraid of the side effects. There are many, many ways to manage them as they come along. One thing that my doctor talked about, so this is doctor number 2 in one of our very early meetings, was his relationship with his colleagues and how they often present their cases to each other through their own chat group and share their thoughts on how to troubleshoot things as they come up. That was comforting for me to know that despite all of his years of experience, that should there be a time when he did not have all the answers, that he knew where to go and he had established relationships with other colleagues to consult with. I liked his strategic thoughts, his willingness to think outside the box, how we would try this or we would add that if needed. He came across to me as a problem solver, a strategic thinker, and he had no problem taking an aggressive approach if that's what I wished to do. He also came with years of experience and was highly respected in the world of kidney cancer, so I was very lucky. Both doctors explained a little to me about access to drugs, the insurance coverage versus compassionate care coverage directly from the drug companies versus government-supported options. We talked about how different drugs are administered. Some require travel to be given through IV monthly, and some are in pill format that you can take orally at home. I know other patients that I've met along the way that are at different stages in their fight. Some have been at it for 20 plus years already. Their children are grown and married. And so for some, quality of life with minimal side effects is their priority. In that case, maybe a more conservative approach to care is a better fit. So make sure you as a patient communicate what it is that you want, whether that be longevity or quality of life. For me, it was longevity. Whenever possible, I think it's important to schedule that first appointment at the end of the day so that you can both take the time to get to know each other and go over the options together without feeling rushed. And then if there is only one thing that I could add that I wish that I had walked away with was a pamphlet on reliable websites to go to. So something like Kidney Cancer Canada, Smart Patients for peer-to-peer support, and of course the IKCC website, which is full of great resources just to stop us from going to Dr. Google.
Yeah, no, those are all excellent tips, truly. So thank you for sharing everything, and those are really good points. So I'd also like to turn to Mr. Hitesh Shah. So thank you so much for joining us. Good evening from India.
Hi, my name is Hitesh Shah and I'm caregiver on behalf of my father. Actually, my father detected kidney cancer in 2010 and he has a tumor in right kidney. So when it was detected, we approached a few doctors and then decided to go with the best option. And all the doctors suggested to go and operate because the tumor is big in size and can't remove. So then they removed his kidney. Thereafter, there was no further treatment so far for next 7 years, and he was fit and fine. And after 7 years, there are few spots again detected in the lungs, and then then again we contacted doctors again, and then we took another approach like oral approach for the therapy, and right now he's fit and fine and he's doing well in his life. He's almost about 72 at this age and he's doing everything on his own. So anytime I would suggest that anytime if you come across this kind of a situation, then you should always approach multiple doctors and see which best option treatment you are getting from the doctor, and then choose one of the best which is suitable to you. Always keep your one of the family member with you so they all know what is going on with you, and they can ask the certain question if needed to the doctor. And doctor also knows that as a family member you are there with the patients. uh, so that is what. And you can ask the doctor what are the other resources available for the treatment, like surgery option or any oral options, any other therapies which suits your body. If you can find and see if you can get some contact whom you can talk, who treat by that doctor in the past. So that is also another option, to talk to those patients and see how they are working in their life and what are the other side effects or anything. Of course, the side effects are different to the patient to patient, but at least you can get a basic idea. And always have a faith in your doctor. Those are the people who are going to help you in your next journey. Those are the people who are going to guide you based on their experience in the past, that will help you out to live your life in a better way. So always have a faith in your doctor first, and makes and always don't afraid to ask any question. Always check with them what are the next. Always also make sure that if you have to go for the test or any particular scanning or everything after a few months or after a year, because in my father case I have to go with the uh, uh, blood checking and the scanning every 6 months or 2 months, and then you have to meet the doctor every time. So always check with the doctor that if we have to make sure that we have to check, these are the things uh, every now and then. So that will help you out to make sure that this cancer won't spread in your body and you can have a better life. So this is what I would suggest to have a.
All right. So thank you so much. That's very important points, all of you. Just one quick question for all of you, briefly. Were clinical trials discussed during your treatment options?
In my
Yes.
case, yes.
Yes.
Excellent. And Megan, for you?
No, they didn't apply.
Okay. So there's just there's a fair amount of variation, but it didn't apply in this case. So presumably you may have been asked if it had applied. So, okay, well, thank you all of you for your expert opinions, and it's been an honor having you as a panel here. So we're going to turn to some questions now. We have a discussion. So if you could put up the next slide, please. So we have questions that were submitted during the registration process, and we have a number of those. And there are also questions that are asked during the live chat during the webinar. And hopefully I'm unable to see that. So hopefully I'll be fed that if there are relevant questions. But I'd like to bring up the panels again. So I think we have a very interesting first question was having to do, 1 second. I have to pull up my questions 1 second. Lost here. I can kick off with Dr. Yonash. There was a question that was asked about for non-clear cell. What are some of the options available for treatments there? And you don't have to be specific, but are there, we don't have a lot of evidence on that. How do we go about that?
Yeah, so there's been an upsurge in information in the past couple of years about non-clear cell. And first of all, obviously non-clear cell is a number of different diagnoses, right? So there's clear cell renal cell carcinoma, but then there's also papillary, chromophobe, medullary, collecting duct. So it's very important, I think, for the patient and caregivers to know what subtype it is. At this point in time, in 2022, we do have emerging data that there are specific types of combinations or drugs that are probably a little bit better than others as a function of this. So once again, this is a question I think that it behooves the patient and the caregivers as well as the physicians to address with regards to what the options are that are available.
Right. And here's a more open question to actually all of you. Is from a clinician's and a patient's point of view, how do you balance being confident that your doctor knows their stuff or with building confidence that they don't pretend to know everything and are open to options? Does anyone feel called upon to respond to that?
Well, I'll just chime in from the practitioner perspective. I always want to make sure that I am honest about what I know and what I don't know. And I try to do that. I think I'm not afraid to do that. I believe ultimately that builds trust. But what it is it's we don't know this, but here's how we're going to try to find out. And so that's how I try to deal with that. But I'd love to hear others' opinions.
Yeah, I think Amy mentioned something about that also, how comforting it was knowing that there was an actual discussion and a network available behind her, underlying her, that decision making. So Amy, do you want to add anything to that?
I think I found that all the way through my whole process, whether that's treating the cancer or treating the side effects, the way that my treatment team or my doctors have worked together collaboratively, that's built a great deal of confidence in me. The way there's just no egos between them at all whatsoever. They talk freely with each other, bounce things back and forth, acknowledge that maybe one theory is a great theory, but not quite sure if that's the right thing, and somebody else takes a different approach, and that builds a great deal of confidence in me. I like to see how they work together.
But actually, Hitesh, he brought up a point too, is it's important to, in some cultures, it's more important to put faith in your doctor. And that might be something that's more relevant in other cultures too. This is meant to be a global discussion, and being respectful to all cultures. How do you feel that works in India, Hitesh? You're on mute.
Sorry.
Thank you.
In India nowadays, many options are available. There are many well-known doctors and doctor panels out there who help you out to go for this treatment and give you the correct guidance. So I think in most of the time people go with the experienced doctor who are well known in this oncology field. So that way they are sure that they are getting the best treatment, and they can put a faith in the doctor, because they know that they are with the correct doctor, and they are going to give the correct guidance to them.
Right. Thank you very much. And so there's some questions that were sent in about clinical trials as well. And perhaps, Dr. Jonas, you could answer this as, how long does a clinical trial usually run for?
That varies very much according to the treatment that's being delivered. And if you have an individual, for example, where we're using what's called adjuvant therapy, where we are trying to give preventative treatment for a defined period of time, that trial may run for a year or so. But if we're dealing with individuals who have advanced or metastatic renal cell carcinoma, at the end of the day, it ends up being as long as the treatment works. And so this could be weeks, months, or years. And so I have some patients that have been on clinical trials now for many years because of the fact that the treatment has continued to work.
Oh, that's excellent to hear. Do you have anything to add, Dr. Govender?
No, I echo Dr.
We're here. I'm having some problems hearing you.
So I echo Dr. Jonas's statements. In the adjuvant setting, it's usually for a defined period of time, and in the metastatic setting, it's usually after disease progression or any tolerable toxicity.
It's very hard to hear you, I'm afraid, but we'll see. Maybe they can do something with that. And if you're in a country where there aren't many treatment options, is there still value in the patient or the clinician instigating the conversation? That's a good question for Dr. Govender. If you could try and speak close to the mic. I'm not sure why we're having these problems.
Could you repeat the question, Rachel?
Yeah, the question is in a country or a health system where there aren't that many treatment options, is there actually is it important to make sure that the conversation between the doctor and the patient explores all the options if there aren't many options?
Undoubtedly, I think my work in the States for many years, and to date, there aren't any biologicals for renal cell carcinomas. We don't have any VEGF-TKIs. We don't have any checkpoint inhibitors. So patients with advanced renal cell cancer in the States, like in South Africa, are managed symptomatically. So despite that, I think it's important for the clinician to mention all these standard of care options. Patients can then perhaps look at avenues such as self-funding or access to clinical trials to perhaps look at getting access to some of these drugs. But you're quite right, it's an exceedingly challenging and frustrating, sometimes sitting at full face, knowing that we have wonderful drugs in our armamentarium, and yet we can't use them.
Right. Okay. Thank you. I hope that I think I could hear most of that, but we are having problems with your sound, I'm afraid. It might be the internet. I'm not sure. So I'm going to move on to this. There's a great variation in treatment availability by country, especially for systemic therapies. Dr. Jonas, could you overview strategies that a patient or an advocate could pursue to address lack of treatment in their country? And I'd like to ask some patient advocates as well that question.
Yeah, I think, depending on which drug, there are some drugs that now, like, for example, I actually won't mention specific drugs, but there are some drugs that are now coming off patent. and those drugs will then become available, a little bit more broadly worldwide from a cost perspective. There are pharmaceutical companies will also then have expanded access programs for up and coming exciting drugs that might then also become available in certain markets where it's not yet approved, but they're working on trying to get the approval. So it's important for the physician, as well as I think the patient advocacy groups within that country, as well as the patient and family, to really be able to acquire that information and see what kind of options there may be to access drugs that might not otherwise be easily accessible.
All right, thank you so much. And Amy or Megan or Hitesh, do you either any of you have comments about that as well?
This is something, honestly, I'm just learning about the politics behind how we get access to the various drugs for different people. I'm finding that even within Canada, province to province, it's different. And there's other first world countries that don't have access to nearly the same options that I do. So I know I'm very privileged with where I live and the options that I've been given. But yeah, how we advocate for others to have the same privileges as me is something I'm still learning about.
Well, you raised a very good point about even differences within a single country, province to province, can be a substantial burden, in fact, for access to treatments. And I know that in Canada specifically, there are some efforts being made to try and uniformly approach that. So, I mean, those are difficult things to do, and I'm not asking you specifically about that particular action, but it's a very complex situation, definitely, for sure. So, Megan, would you have any comments on that either?
Well, I don't have any comments, personally, but it does make me wonder, and maybe this is a question Dr. Jonash or Dr. Govinder can answer, is since COVID and in the era of telemedicine, has that made clinical trials more accessible for patients?
Yeah, great question. And in theory, it should, and it has to some degree, because of the fact that there are restrictions that are driven by regulatory bodies with regards to who can interact with whom from a video perspective. But some of the follow-ups that may occur on a clinical trial can be done via video, because the physical examination is not absolutely essential for that particular interaction. I'm part of a consortium of kidney cancer treating centers where we're trying to incorporate these types of tools into our care algorithm. And I personally have now my clinic itself is 50% virtual, 50% in person. So we're trying to incorporate these techniques into our overall care, and I think it should make things easier, but it's a little bit of its infancy, and we have those multiple elements of the technology, access to technology, as well as the regulatory exigencies that sometimes make this a little harder than we'd want it to be.
Thank you. That actually feeds into one of the questions posed by the audience as well, which was about access to rural patients and whether that I think that was from Christine Collins in Canada, and how to get second opinions. Do you think that some of the technologies that were introduced as a result of COVID, thank you, any guidance for our kidney cancer patients in remote or rural areas and how to access second opinions? Do you think that this is the way forward?
Again, it should be, and having personally, I personally, am doing this with some of our patients and creating some sort of a system where where geography impedes the ability to interact with centers of excellence, where being able to actually have this type of a consultation where perhaps some of the information, like the imaging studies and the labs, are shared electronically, but then the opinion is provided in some sort of a video interaction format. I think this can be a quality interaction and can actually really add to the value of a patient's care if done correctly. And we really should push, I think, but internationally, we need to push our governments our medical regulatory bodies to embrace this, because I believe it does provide quality for patients.
Thank you. And from the patient point of view and caregiver point of view, have you experienced telemedicine?
No, I have not.
No?
I have. So my surgery happened in March.
I hope not via telemedicine.
Not the surgery part, but post-surgery, I had my post-surgical visits via telemedicine, and I remember standing in front of the computer, holding my shirt up, showing the scars, and they were looking, and it looks okay, and I think it definitely it helps. I think it should help patients have a better access to providers. It just depends on what you're seeing the doctor for. I don't think it's as effective for certain types of appointments, but
yeah.
It helps.
What about you, Amy? Have you experienced it?
I have, but not to the same degree as Megan. Mine have been the very just touch points, just catching up on how this or that is. It's nothing. So something that could have been done over the phone, really. Not a really important appointment. Those have still been in person.
All right, thank you. So there's actually been another question that was sent in that I think is interesting. It's clearly from the patient perspective, and the question is should I or could I find a clinical trial? My oncologist hasn't been encouraging that. That's a difficult topic. What should a patient do if their clinical oncologist hasn't brought it up or hasn't been particularly encouraging about that? Dr. Govender, do you think you're able to try that?
Yeah, sure. Can you hear me?
Yes.
I think that it's worthwhile if you think that you're not getting adequate treatment or best practice to, again, as we said, seek out a second opinion, discuss the clinical trial with the second oncologist. You're fighting for your life, so you want the best treatments available. And you've got to explore every option. You've got to leave no stone unturned in doing so. So I would strongly encourage that.
Right. And Dr. Jonash, what would your expert opinion be there?
Yeah, absolutely. I think that, a second opinion, I welcome. If a patient wishes to have a second opinion for anything, we help them do that. And I think that's part of that's part of quality care, to make sure that these questions are answered. And if we don't have the answers, that we find people who are capable of providing them.
Right. And since I've got you on off mute anyway, so there's a point made about from the live chat as well. Is it important to note that the number of drugs available doesn't correlate with survival in kidney cancer? Does the access to a number of drugs actually correlate with survival?
So I'm not aware of a study that demonstrates that, but I think it is fairly clear that a couple of the agents that have become available in the past 15 years, the targeted drugs as well as the immune modulatory drugs, having access to representation of each of those classes, I think probably does matter. But whether you have 5 or 6 in category 1 and 5 or 6 in category 2 versus just having access to these drugs probably is less important.
All right. Dr. Govender, do you have anything to add there?
I also am not aware of any clinical trials that have explored this, but it goes with a very simple principle that the more drugs you have available, the more options you can afford the patient. Especially in the metastatic setting, we talk about lines of treatment, first line, second line, third line, and so forth. So naturally, the more drugs you have available, then intuitively, the longer you can stretch the patient's journey.
All right. Now, I think that the patients and the caregivers we have here are fairly active in the management of their disease, but there are some patients that just want to be told what their treatment will be, and they don't want to participate that. Is there some value still in having that discussion if you feel like it might confuse them or even distress the patient? Dr. Jonash?
This is part of having that empathetic conversation and reading the room and understanding what the needs of the patient are. It is not my my place to tell the patient what the patient should want to know. What I'm there for is to provide a tableau where, you know, we can state that there are discussions we can have and make sure that the patient and the family members are ready to have that conversation. And if they are, we provide that information. And I've heard more often than not, you know, it's like, whatever you think is best, doc. And if that's the case, you know, I will make sure I will get affirmation that that's how things should be done, and then I will try to do my best to put myself in the place of the patient. I would call it the brother or sister or parent sort of thing. You know, if this were my parent or this were my sibling, how would I treat them? And then use my best judgment on how to actually move forward. So, I mean, it is a form of shared decision making, I guess, but we do have to tailor it to what the patients wish to know.
All right, thank you. So I think we're rounding off this part of the webinar right now, and I'd like to we had a very interesting request from our patient panel that Amy would like to give the thank you. So as part of the contribution for all the patients and caregivers, it was decided upon that she could be our spokeswoman here.
So on behalf of all of us kidney cancer patients, I would like to say a very sincere thank you to everyone that's ever donated to cancer research, to all of the healthcare professionals that have dedicated your brilliant minds to working in the world of kidney cancer, whether that be in the research development, direct patient care, or the lobbying for access to care. We say a very big thank you to all of you.
Well, thank you. It's extremely well for it. Well, on my part, I'd like to thank the panelists. Each and every one of you made very interesting comments, and it was a good discussion. I would also like to thank Grey Matter for their work and the whole team for the World Kidney Cancer Day, their excellent support. I'd like to thank the technical staff for today, of course, and our sponsors made it all possible. So just as a final housekeeping note here in the final minutes, I'd like to just say that this meeting has been recorded, and it will be available hopefully within about 24 hours with subtitles in various languages. And you're welcome to access it, and I encourage you to share it. And I hope that this will give some answers and raise some questions for everyone. So on behalf of the entire World Kidney Cancer team and the IKCC, I thank you for listening.